I'll provide it in exam-style format with depth for each section so you can use it directly for study or assignments. Paget's disease of bone on Paget's disease of B. Paget's disease of bone, PDB, also called osteitis deformans, is a chronic metabolic disorder of the skeletal system. It results from an imbalance in the normal bone remodeling process, where excessive osteoclastic resorption is followed by abnormal, excessive, and disorganized osteoblastic bone formation. This leads to structurally weak, enlarged, and deformed bones. It is the second most common metabolic bone disease after osteoporosis. It can affect one or multiple bones and progresses slowly. Many patients are asymptomatic and diagnosed incidentally during X-rays or elevated alkaline phosphatase levels. In symptomatic cases, patients present with bone pain, deformities, fractures, and complications such as hearing loss or arthritis. Definition. Paget's disease of bone is a chronic focal disorder of bone remodeling characterized by increased osteoclastic activity followed by compensatory osteoblastic bone formation, leading to enlarged, deformed, structurally weak, and hypervascular bones. 3. Etymology. Named after Sir James Paget, 1814 to 1899, an English surgeon and pathologist. He first described the disease in 1877 under the term osteitis deformans, suggesting inflammation as a cause. Later studies proved it is not primarily inflammatory, but rather a disorder of bone remodeling. The disease should be distinguished from Paget's disease of the breast and Paget's disease of the vulva, which are unrelated. Hannah 4. Epidemiology. Age. Rare before 40 years, prevalence increases with advancing age. Peak incidence occurs in people 55 years. Gender. More common in men than women. Male-female ratio equals 1.5 to 2:1. Geographical distribution. High prevalence in UK, Western Europe, North America, Australia, and New Zealand. Rare in Asia, Africa, and Scandinavia. Prevalence estimates 1 to 3% of people over 55 years in endemic regions. Declining prevalence in some countries, possibly due to environmental changes. 5. Types 1. Monostotic Paget's disease involves a single bone, 20 to 30% cases, less severe and often asymptomatic. 2. Polyostotic Paget's disease involves multiple bones, 70 to 80% cases, more likely to cause deformities and complications. Common bones affected: pelvis, most common femur, tibia, lumbar spine, skull, and humerus. HAR6, causes exact cause is multifactorial and not fully established. Genetic factors: mutation in SQSTM1 gene, sequestosome 1, and others involved in osteoclast regulation. 15 to 30% of patients have a family history. Viral factors: viral inclusions, similar to paramyxoviruses like measles virus and respiratory syncytial virus found in osteoclasts. Environmental factors: higher prevalence in specific geographic areas. Possible link with nutrition, toxins, or infections. 7. Risk factors: age, rare 40 years, common 55 years. Sex, men more affected than women. Family history, strong genetic predisposition. Geography, high prevalence in Europe, low in Asia, Africa. Genetic mutations, SQSTM1, TNFRSF11A mutations. 8. Complications: skeletal complications, bone deformities, bowing of legs, enlarged skull. Pathological fractures, low trauma fractures, osteoarthritis due to bone enlargement and joint misalignment. Neurological complications: hearing loss, involvement of temporal bone. Nerve compression, radiculopathy, spinal stenosis, cranial nerve palsies. Cardiovascular complications: rarely high-output cardiac failure due to increased vascularity of bone. Malignant transformation: osteosarcoma, fibrosarcoma, or giant cell tumor, 1% cases. Metabolic complications: hypercalcemia, particularly with immobilization. Hammer 9. Pathophysiology. Normal bone undergoes remodeling through balanced osteoclastic resorption and osteoblastic formation. In PDB-1, osteoclastic hyperactivity, increased bone resorption. 2. Compensatory osteoblastic activity, excessive bone formation, but the bone is woven, irregular, and weak. 3. The remodeled bone is structurally disorganized, loss of lamellar structure, enlarged and deformed, hypervascular, increasing risk of bleeding during surgery. Phases of disease: osteolytic phase, intense osteoclastic activity. Mixed phase, simultaneous osteolytic and osteoblastic activity. Sclerotic phase, abnormal new bone predominates, enlarged but weak. Share 10. Signs and symptoms: asymptomatic, 70 to 80% cases. Bone pain, most common presenting symptom. Skeletal deformities, bowing of legs. Enlarged skull, increased hat size, frontal bossing. Spinal kyphosis. Fractures, pathological, occur with minimal trauma. Neurological symptoms, hearing loss, radiculopathy, spinal stenosis, nerve compression. Other features, warmth over affected bones due to increased vascularity, osteoarthritis, especially in hip and knee. Natural 11, medical diagnosis, clinical evaluation, history, symptoms, family history. Laboratory tests, elevated serum alkaline phosphatase LP, marker of increased bone turnover, normal calcium and phosphate unless complications occur. Imaging, X-ray, lytic lesions, bone expansion, cortical thickening, coarsened trabeculae. Bone scintigraphy, bone scan, detects extent and activity of disease. CT MRI, used to evaluate complications, nerve compression, fractures, malignancy. HARV 12, nursing diagnosis, chronic pain related to bone remodeling and deformities. Impaired physical mobility related to bone deformities and arthritis. Risk for injury and fractures related to weakened bones. Disturbed body image related to skeletal deformities. Deficient knowledge about disease management. THIRD 13, medical management, bisphosphonates, first-line therapy, alendronate, risdronate, pamidronate, zoledronic acid. Suppress osteoclastic activity, reduce bone turnover, and normalize ALP. Calcitonin, alternative in patients intolerant to bisphosphonates. Analgesics and NSAIDs, pain relief. Surgery for fractures, deformity correction, joint replacement, or decompression. Monitoring regular ALP levels, periodic imaging. 14, nursing management, assess and manage pain. Encourage safe mobility, use of walking aids, physiotherapy. Prevent falls and injuries. Provide skin care over bony deformities. Monitor for complications, fractures, hearing changes, cardiac symptoms. Educate patient about medications, nutrition, and lifestyle adjustments. Provide psychological support for body image and chronic illness management. 15, treatment options. Pharmacological, bisphosphonates, mainstay, calcitonin, surgical, osteotomy, joint replacement, internal fixation of fractures, supportive, orthotics, physiotherapy, pain management, adequate calcium and vitamin D supplementation. 16, psychosocial interventions, counseling to cope with chronic pain and deformities, addressing body image issues, support groups and community resources. Family and caregiver education for home care, vocational rehabilitation for patients with work limitations. 17, prevention, primary prevention, not possible, cause not fully understood. Secondary prevention, early screening of at-risk individuals with family history, monitoring serum ALP and bone scans. Fall prevention strategies to reduce fracture risk, adequate calcium and vitamin D to support bone health. 18, conclusion. PAGET'S disease of bone is a chronic skeletal disorder resulting from abnormal bone remodeling. Although many patients remain asymptomatic, some develop pain, deformities, fractures, and complications like hearing loss and arthritis. Early detection through biochemical and radiological studies is crucial. Treatment with bisphosphonates is effective in controlling disease activity, reducing complications, and improving quality of life. Comprehensive management requires medical, nursing, and psychosocial support to help patients adapt to the chronic condition. Thank you. Have a nice day.